let's talk about lupus nephritis then. First, we'll go over pathologic classification of lupus nephritis, then we'll be moving on to presentation and prognosis, and then you can think, of course, you always cradle the conversation of treatment within a conversation around prognosis. Okay, so let's move to pathologic classification system. We look for certain features in all of these lupus nephritis classes, okay? But I will highlight that these features are not pathognomonic, okay? It's really, you're building a case of lupus nephritis, but you can't really say there is a diagnostic feature that is pathognomonic for the diagnosis of lupus nephritis. There's sometimes this equivocation on making the diagnosis. Certainly, you've heard for now, multiple times the full house staining. Remember, full house, if you're not a poker player, is a combination of a 3 of a kind and a 2 of a kind. So you have the 3 immunoglobulins that are present, IgG, M, and A, and then the 2 complement components is your 2 of a kind. There's C1q and C3 that's present. Often there's C4 as well. Okay, but that's not necessarily part of the full house statement. Okay. Tubular reticular inclusions are also features that we're looking for. Remember that we're looking in the endothelial compartment. Pranav, here's that foot processes that are really very discrete here. You can see again the gaps between the foot processes that are, if you zoomed in close enough, you'll see the slit diaphragm. And then here we are, the basement membrane. Here's the endothelial cells. So notice that these kind of round structures, tubular structures within the endothelium are these tubular reticular inclusions, which are felt to be organized ribosomal RNA. Okay, that happens under the influence of systemic inflammation, in particular with high interferon levels. One can see these tubular reticular inclusions in Covan. You can see this in HIV. You can see this with obviously interferon therapies. So this is not, again, a specific finding for lupus nephritis. This substructure to immune complexes that look like fingerprints would also be a clinical clue, but once again, not pathognomonic for lupus nephritis. Okay, I've already made this statement of where you can see TRIs. Okay, now let's move into the various classes that you see on kidney biopsy. Class 1 would be the essentially looks normal or almost normal or on light microscopy, but I see deposits of immunoglobulin and complement on immunofluorescence microscopy, and I also see those deposits on electron microscopy. But once again, the light microscopy is normal or only very mildly abnormal. The earliest finding is in the mesangium once again. Again, you can't see a totally normal kidney. The only thing that I'm seeing is on immunofluorescence and EM, I'm seeing immune deposits that are present. That would be your class 1 lupus nephritis. Jumping ahead, we don't typically treat those. Okay, because they have good prognosis. And then we'll move on to class 2, which is that clear mesangial proliferative lupus nephritis. So this on light microscopy, I can shuffle in an IgA nephropathy, right? IgA looks typically as mesangial expansion with varying degrees of hypercellularity. The only difference between those two, they look identical on light microscopy, but I'd look under immunofluorescence and see that there's the full house on lupus, and then there's the IgA dominant or co-dominant present on IgA nephropathy. Okay. Class 3 and class 4 are present when I see endocapillary hypercellularity. So that would be diagnostic of a class 3 or 4. I'll make one other sort of side comment, which I know I've spoken to some of you about in GN clinic, that sometimes you can or I would say the pathologist will call this a class 3 or 4, and they would legitimately call it a 3 or 4 based on the International Society of Renal Pathologists. Their pathology classification schema counts active and inactive lesions as when they're calling a class 3 or 4. So let me clarify that real quickly, and then I'll kind of come back to it rather briefly. If I have no active lesions, I just have focal scars or segmental scars that are present in less than 50% of the glomeruli, but I see no endocapillary hypercellularity, the renal pathologist will call that a class 3 still, even though there's no active lesions there. It's all just segmental scars. If that's focally distributed, meaning less than 50% of the glomeruli, they'll call it a class 3. If you see segmental or global scars as well, global being the entire glomerulus involved by scars, and greater than 50% of glomeruli, they'll call it a class 4. So if you just look at the punchline, this is class 3 or class 4 lupus nephritis, you may be tempted to give a burnt out lupus patient mycophenolate steroids. Please don't do that, okay? So that aside, that special case aside, which is not uncommon, we're generally really interested in how much active inflammation there is, demonstrated by the presence of endocapillary hypercellularity. And if it's less than 50% of the glomeruli involved, we call it a class 3. If I have endocapillary hypercellularity and greater than 50%, I call it a class 4. That distribution would be diffuse if I'm greater than 50%. Okay, gone over those adjectives multiple times. I won't belabor it. So I may have these areas of, again, endocapillary hypercellularity, where glomerular capillary loops have, typically mononuclear, but sometimes neutrophils, but usually mononuclear inflammatory infiltrates within capillary lumina, right? That would be endocapillary proliferation or hypercellularity, right? One other sort of side note to make is that even if I don't have a lot of endocapillary hypercellularity, but if I have wire loop lesions, these thickened capillary loops thickened by the presence of larger immune complexes, then I would call that equivalent to an endocapillary hypercellularity. So that's counted as let's call it a pre-proliferative lesion. With all of that immune deposit that's present, this is a inflammatory lesion that's waiting to rev up. Okay, and so that's called that's consistent, or that's counted as a proliferative lesion as well, even if I may not have little to no hypercellularity. Okay, so wire loop lesions are also counted as, let's call it, pre-proliferative lesions. Okay, and then also I've made the comment that if I have a bunch of scars, then that, as the rightmost example conveys, this would be an area of focal sclerosis, which is also counted. And the way they count it in the standard rubric is that they'll say there's an activity score of X and a chronicity score of Y. So they may have a very low activity score and a very high chronicity score if all you see is IFTA and sclerosis without a lot of hypercellularity. Okay. We've already made the comment of the distribution. There is some older literature that there was some value to describing whether the proliferation is global versus segmental. But that has become, I guess, less emphasized. There was a pretty high impact paper that said that having segmental hypercellularity, right, here would be a nice segmental hypercellularity. Well, actually, there's hypercellularity throughout, but this is quite prominently involved. Has prognostically has a negative prognosis, but that's kind of fallen out of favor. It's not really emphasized anymore. You might still see it in a pathology report. Moving to class 5, that's the membranous lupus nephritis, where I see subepithelial deposits. So here would be an example of some, remember, here's the urinary space with the base foot processes, here's the endocapillary space, and these deposits are either intramembranous when you see membrane on both sides, or subepithelial, here's a subepithelial deposit. And again, spikes and holes are what you're looking for. Here are the classic spikes. And then, there's some of these bubbly holes that are present as well, which emphasizes something that Pooja described in her PATH conference yesterday. Okay, how do we discriminate these from idiopathic membranous? Well, of course, the presence of full house staining, the presence of tubular reticular inclusions, and the wider distribution of deposits. If deposits exist beyond simply the subepithelial space, you see deposits in the mesangial compartment, the subepithelial compartment, then I am more likely to call that a secondary membranous. And of course, if it's full house and TRIs, I'll call that most likely a lupus membranous, as opposed to some other secondary membranous. Okay. Class 5 lupus can coexist with 3 and 4. So you'll see 3 plus 5 and 4 plus 5. That is not uncommon. And then finally, class 5 lupus refers to dead kidney, just a bunch of scar. Moving on to presentation and prognosis. Renal involvement is exceedingly common in lupus. So I always make this statement that for every 1 patient we have in GN clinic, there should be 2 in room clinic, because 50% of the patients with lupus will have renal involvement at some point in their disease course. Hispanics and Blacks have more frequent renal involvement than Caucasians and East Asians, and also have a more severe disease course. So that's an unfortunate disadvantage as well. Okay. And renal biopsy is indicated in these cases of renal involvement. The decision of when to do a renal biopsy is individualized. I would say that there's no, evidence-based number like there, where it's clear that doing a kidney biopsy and treating this lupus early makes a big difference in prognosis. There are some variants across practicing nephrologists of when folks pull a trigger on kidney biopsy. That being said, I haven't read I have to admit I haven't read these guidelines, but recently there was a guideline publication that came out, primarily driven by rheumatologists. I'm sure they had some nephrology representation, that makes arguments to an earlier treatment and an earlier diagnosis. But I can say sometimes I'm pushing back and saying, gosh, I don't really want to do a biopsy right now. Just put them on their hydroxychloroquine and let's see if this just melts away before we jump into kidney biopsy. Okay. Predictors of worse outcome, as you can imagine, relapsing disease. We've already gone over the worst prognosis of Blacks and Hispanics. Male patients will often have a worse prognosis, not just in their renal involvement, but their extrarenal involvement. I should say, though, renal disease is the path of death in most patients with lupus. So again, renal disease is common and is the main organ-threatening manifestation of lupus. More common than cerebritis or pneumonitis or carditis, and is again a path of high morbidity and mortality in patients with lupus. And that's why rheumatologists are not on the periphery. They're really involved in the randomized controlled trials that have been done in lupus nephritis, often have PIs that are rheumatologists, because again, they're so plugged into renal disease as a path of morbidity and mortality for lupus patients. Hypertension. Some people have shown some pathologic correlates are associated with worse prognosis as well, but those are less firm. Post-transplant course is generally pretty good, but there is a detectable increase there's a detectable relapse rate amongst the transplant patient, 10% by some numbers. But again, allograft survival seems to be similar to non-lupus patients. And so, as long as their disease is under reasonable control at the time of listing, it still is the preferred renal replacement therapy for lupus patients. Okay. Treatment. Let's go over some general principles first before diving into a couple of protocols. And I'll go modestly over and just try and finish this since we are behind, so I don't get 2 steps behind, just 1 step behind. Partial remission, we define typically as stabilization in GFR, even if it's not normalized, because there may be some irreversible, IFTA and global glomerular sclerosis. But proteinuria reductions by 50%, as well as achieving subnephrotic proteinuria, would be usual definitions of partial remission. So again, going from 10 grams to 4 grams meets the 50% of proteinuria, meets the 50% criteria, but does not meet the second, getting them subnephrotic. Complete remission, we generally looking for pretty much intuitive things like stabilization in GFR, proteinuria that's near normal. Again, they may have this residual proteinuria from those secondary scars. So you may not ultimately get to normal albuminuria, even though you might have treated all of the lupus, all of the immunologic component of their disease. You may not go to normal albuminuria. We're typically also looking for an inactive urine sediment. Another principle that is general in treatment of lupus patients is you as a nephrologist should be prescribing hydroxychloroquine. This is not a rheumatology drug. This is a drug that you as a nephrologist should be prescribing. Hydroxychloroquine should be really part of the treatment of any lupus patient who has any level of disease activity. It has been shown to reduce the risk of organ-threatening manifestations of lupus. And again, nephritis is the most common organ-threatening manifestation. So you are treating the patient's renal disease by putting them on hydroxychloroquine and getting the dose right. It's common that I see patients who are underdosed. Sometimes they're inherited from children's and they're getting, they were smaller back then and nobody's ramped up the dose as they've gotten larger or they've picked up weight. So it has to be given at the adequate dose. What is that dose? Somewhere between 5 to 6.5 mg per kg. We don't typically exceed that because, there is a higher chance of developing retinal toxicity. But let me just say that retinal toxicity is pretty rare and happens usually like 10 years down the road when it does happen. This is not something that should be meaningfully risky in the near term. Okay, treatment is divided into induction and then maintenance, although there is a fuzziness between those 2 phases, especially with the introduction of mycophenolate, because mycophenolate can be used for both induction and maintenance. And so, that has made this more gray. When we were treating everyone with cyclophosphamide, it was pretty clear you were in induction phase getting cyclophosphamide once a month. And now we're in maintenance phase. We're giving you Imuran or cyclophosphamide every quarter. So now that mycophenolate is really a standard treatment, this induction and maintenance phase has become more gray. Okay. We don't know what the optimal duration of maintenance therapy is. I would say that in most cases, I'm using 24 months, similar to the calcineurin inhibitor commitment of idiopathic nephrotic syndrome, which I've told you about. If I have a patient who has achieved only a partial remission, which you believe is immunologic, right? That is to say that residual proteinuria is not just their secondary scar, right? That sometimes you need to rebiopsy to say, oh, this little bit of proteinuria that you still have at 3 years down the road is not because of active lupus nephritis. It's just this FSGS you now have, the secondary scar from lupus. And so you rebiopsy them, and then you decide, okay, there's nothing active here. Really the pathologist may still say, class 3 lupus nephritis, activity score 0, chronicity score 5, right? You should be saying, okay, you don't need mycophenolate, even though the pathologist is calling you lupus nephritis class 3, we can start weaning your immunosuppression. That proteinuria is just your CKD. Okay? Sometimes, you need to rebiopsy. Other times you just say, let's just start weaning it back. Let's see if your complements start falling. Let's see if your proteinuria starts going up or hematuria forms. Let's watch you closely. But, so let me say once again that partial remission is sometimes hard to call, right? Sometimes you have to rebiopsy in order to determine whether you still have a little smoldering lupus or not. But if you have smoldering lupus, you're not going to, there's nobody waiting outside, is there? Okay. With smoldering lupus, I guess I can go a little bit further then. Smoldering lupus, you're not going to pull back, right? If you think there's smoldering lupus and you start pulling back on immunosuppression, well, what do you expect to happen? Things to accelerate. So you're not going to necessarily stop at 2 years. Or if you have somebody who's already relapsed 3 times, in that scenario, you might also say, gosh, we're not going to stop anytime soon, because every time I've stopped in the past, you've relapsed. So that's going to also be a determinant of duration of therapy in some cases. Okay. Other supportive interventions, don't forget about your contraception, because this is a disease 9 times out of 10 in women. And most of the time it's young women of childbearing age. So this is clearly something you have to be thinking about. Let me just say, on the social side of things, Texas is really hard to get a therapeutic termination of pregnancy now, even when you think there's a risk to the life of the mother. There's a lot of barriers to even doing it in that context. So it's really tough now. So you really got to emphasize this. Every year we have unplanned pregnancies in GN clinic. People say, I'm not sexually active. We don't need to talk about that. And, it happens every year. So don't take, I'm not sexually active, and then, don't talk about it anymore. You still have to you have to really explain this is important. PJV prophylaxis.
Why non-estrogen containing?
Thanks for the question. Why not non-estrogen containing? Because, again, this is a disease of females. There is some evidence of increased relapse rates around the time of pregnancy, where estrogen levels are particularly high. And so estrogen theoretically is an inciting factor in lupus. Okay. Again, that would explain the difference in gender representation of lupus. That being said, there's single randomized control trial looking at, and it's in New England Journal, the old paper, estrogen versus non-estrogen containing contraception in lupus patients, that showed no clear evidence of an increase of disease. That being said, with other choices available, I do not suggest people start estrogen-containing contraception. And I would say that's aligned with practice patterns from our women's health clinics. I don't see them prescribing estrogen. It's usually progesterone or IUDs. Okay. Complement levels can be followed. I don't have a standard protocol. Check them a couple of times a year. There could be some patients that drop their complements before relapse. That is not reliable, though. So don't use that as there's still nobody out there. Don't use that as a decision point. Okay. So something to think about, but not really as a reliable one. Okay. So there is a small prospective randomized control trial that says that giving a short course of steroids for serologic worsening before clinical worsening reduces relapse rates and also results in an average steroid dose that's less over the long term because you're treating early and briefly as opposed to long and hard later on. Okay.
Value.
Not really. But that being said, the question is, do I practice that way? Look for serologic worsening, give steroid courses. I have to soften my response. I don't treat somebody with steroids just for a serologic worsening, but I treat plenty of extrarenal lupus in GN clinic, right? So, it's a multi-system disease. And as you're making these determinations of when to pull back, I should add this as well, I would not pull back somebody's mycophenolate if their extrarenal disease is terrible, right? If they're, having constant, pain relapses or their skin disease, they're getting bullous lesions, we're not going to pull back on immunosuppression, even though their kidney disease has been in complete remission for 3 years, right? So you have to take a holistic approach. You got to ask about, and examine for synovitis, and you have to, I would treat a serologic worsening with, so good. I would treat a serologic worsening that is paired with some signs of extrarenal relapse. Okay. So when we look at remission rates, here's from the randomized controlled trial data. The point I'm trying to convey to you is that, we don't have perfect solutions for this treatment. If you look in randomized controlled trial data, what is the response rates defined as complete or partial remission at 6 months with the standard inductions that we're using in these trials? 70% of patients on the good side. So you have a lot of patients who even at 6 months are still not controlled. Now, a lot of that has to do with compliance. You always, let me make this point once, and then I'm not going to make it again. There are so many patients that get into I'll call it a rut, where a provider has treated them with regimen X, failure of treatment, regimen Y, failure of treatment, regimen Z, failure of treatment. Now we're starting to throw Hail Marys, where, my intervention is like realizing through dissection the chart, talking, very deeply with the patient, they weren't really a treatment failure. They just didn't take their meds. And so you run out of runway if you keep calling this treatment failure to X, Y, and Z, and then you get to these points of no good options. There's plenty of patients where I've just used standard treatments at right doses with therapeutic FK levels and good buy-in from the patient and honesty, and we win, right, in a patient who is refractory disease. So, I can't stress enough that before you call somebody treatment failure, you really need to dig for truth, okay? Because it's gonna be a bigger problem later on for you. It's obviously good patient care, but if you keep running out of runway, you're gonna have worse outcomes in the treatments for your patients. Complete remission rates, though, are achievable if you just keep going. Okay, so this is another point to make, that looking at randomized controlled trial data, you can reach complete remission rates that are, you can have further people fall into remission as you push beyond 6 months. If you're having a response in those first 6 months, you're able to taper prednisone, I would keep going as long as they're not having side effects with their full dose mycophenolate. That's why these induction and maintenance phase for mycophenolate in particular is a gray zone. If somebody's responding and, we're at 6 months or 9 months, I'm not automatically going from 3 grams a day to 2 grams a day just because they're out of induction phase. Okay, if they're still got residual active disease, and I haven't reached a complete remission, I may just, again, keep going 3 grams a day. You're not having nausea, you're not having pneumonias or UTIs. Let's keep going because people fall into more completes and more partial remissions. Okay, as you push out, even into the years 1, 2, and up to 3. Okay, renal relapse is common. Okay, so here's a rate of relapse that I'm invoking. Blacks and Hispanics and partial responders are more likely to have these relapses. Okay,